Today we will talk about femoroacetabular impingement, which you're all familiar with, but it's basically when you have repetitive trauma from flexion and internal rotation, an abnormally shaped femoral necks and acetabulum, which leads to chronic bone reaction and traumatic injury, articular cartilage injury, degenerative subchondral bone disease, and pain. And the initial abnormality can be congenital, an abnormal congenital shape, or subcapulofemoral epiphysis. But most of what we deal with in sports medicine anyway is probably congenitally normally shaped bones, but with repetitive trauma that have to do with some athletic activity, you get impaction between the acetabulum and the femur, and that leads to a bone injury, and the bone tends to heal that with hypertrophic bone formation, which develops both cysts as well as new bone formations and bumps in especially the femoral head-neck junction region, which then can go on to increase the risk of repetitive trauma. And there are two types that have been described, but almost everyone is a combination of both. One is the CAM type, where the femoral head at the head-neck junction isn't perfectly spherical. You've got a bump there, which means that when you rotate the femoral head into an orientation where typically the anterior and anterior superior head-neck junction impinges upon the acetabulum, it's no longer spherical, but there's a bump there, so it impinges more and produces damage. And then a pincer type, which is basically where the acetabulum is too large and does not allow full range of motion. And there are a lot of ways that these have been categorized. You have pincer type acetabular disease. You can have coxa profunda, protrusio, anterior acetabular retroversion, prominent posterior wall. Any of those can produce increased potential for impingement involving the acetabulum itself. And on the femur, you can have a bump. And if it's superiorly, it's called a pistol grip deformity, which we'll see. Anterior superiorly is more common in sports injuries. And then you can also get a femoral retrotorsion, or that we'll talk about, which can also lead to a CAM-type impingement. So kind of the normal configuration of the hip we see here, we can have full range of motion without impingement. If you have excessive coverage of the acetabulum, then you can get impingement far short of normal motion, as we see here. Or if you have an abnormal bump, you can develop a CAM-type impingement. So this would be pincer-type impingement. This would be CAM-type impingement, where that increased bone of the femoral head-neck junction impinges upon the acetabulum. And there are a number of clinical tests which people use to check to see if they can reproduce pain in the position where you would expect the impingement to occur. Another thing that people make a lot about is a retroversion of the acetabulum. And if you have a nice non-rotated view, this is of a cadaver pelvis. The normal pelvis, if you follow the anterior wall and then come back around to the posterior wall, they shouldn't overlap. If the anterior wall comes too far forward, then you get this figure-8 configuration when you draw these lines. And this increased bone of the anterior aspect of the acetabulum can be a location where you can get impingement. So this is just kind of the normal, and then the abnormal would be whether if you follow the anterior wall of the acetabulum, it comes lateral to the posterior wall, and this can be the area of impingement, called the figure-8 side. If you look at this on CT, is what you can see is increased prominence of the anterior superior acetabulum, which can have a bump here, which can lead to impingement on the femur. And the other thing that you can get with this it would be the bump on the femoral side, which is something much more commonly discussed. And this is where instead of the anterior head neck junction of the proximal femur coming in and being indented at the head neck junction, what you get is in the neck area, you get this abnormal bony hypertrophy here, which is generally probably due to repetitive traumatic injury here in hypertrophic bone formation to heal that repetitive injury, and commonly seen in sports like gymnastics and hockey. And this then, when you rotate the femoral head and the acetabulum comes along here, it starts impinging, the cam-type impingement, right when you get to this hypertrophic bone formation. And as all of you know, you can then measure an alpha angle, which we'll go through in great detail, and this would be an abnormal alpha angle. Okay. Now, I'm sorry. This is called a pistol grip deformity. If you have this abnormal bump involving the superior head neck junction, what this looks like is an old-fashioned Derringer, where this is the handle, this is the gun itself, and you get this prominence right here, which is called a pistol grip deformity. This is a very superior area of potential cam-type impingement with the pistol grip deformity. And that's right. And this probably, some of it may be due to repetitive trauma, but all of this is probably due to hypertrophic bone formation from subtle slip capital femoral epiphyses. Now, the alpha angle has been originally described on X-ray based technologies, where you basically have the femoral head, you draw a line right down through the middle of the neck, you go to the center of the femoral head, then you come around, draw a circle around the femoral head, see where the bone and the circle of the femoral head intersect, and then measure this angle, and that's called the alpha angle. Now, a problem that you have with impingement is that you can have impingement anywhere around a 365-degree circle around the head neck junction. And what we typically measure with CT and MR is basically one location around that 360-degree circle. So there's some basic limitations in measuring the alpha angle because it really doesn't see the full 3D anatomy of the hip joint. Secondary signs that you can see, this is a pistol grip deformity, which we just talked about here, and this is an acetabular ossicle there, which you can be seen, which is most likely secondary due to a Pincer type abnormality where you have increased center edge angle, increased acetabulum here, and with chronic repetitive trauma, you develop an acetabular fracture along the edge of the acetabulum. And this is often called an os acetabulae. In the old days, it was thought to be congenital, but I think almost all of these are really due to trauma now. Okay. The other thing that can be of importance in developing impingement has to do with the torsion angle. This is really much more important when it comes to doing hip replacements. And one of the things that you do, and the reason you do the knee when we do CT scanning for hip replacements, is to look at the angle between the coronal plane of the knee versus the coronal plane of the proximal femur. And that's a torsion that you normally have in the femur. So the two aren't perfectly aligned. And you can measure that by doing an axial image through the head neck of the proximal femur and also through the knee, looking at the posterior condyles. And this is called the torsion angle, the angle between the two when you put them together. And you tend to get cam-type impingement if you have a small torsion angle, and a Pincer type if you have a large torsion angle. But I don't really use this commonly in evaluation for impingement. And this just goes through how you may be able to get impingement, especially with even sometimes a Pincer type impingement, if this torsion angle is abnormal, causing an abnormal positioning of the proximal femur with respect to the acetabulum. Another torsion angle is the epiphyseal torsion angle, which we already talked about when we talked about slip capitofemoral epiphysis, where you draw a line along the center of the neck of the femur, and then you draw a line basically through the center of the epiphysis, and you can get this angle here between the two, which we talked about. And if this is greater than 20 degrees, it's typically an indication that you have a slip capitofemoral epiphysis. When this happens, you often get hypertrophic bone formation at the margins of the growth plate, which can lead to impingement, especially superiorly here, or anteriorly superiorly. Now, so these have all been kind of classically described findings in plain films, and they were all nice, and people were very excited about them. And then somebody came along and did a study to see how useful these things really are. So the problem with a lot of this kind of interesting information is that it doesn't hold up well when you actually get real data. So this is the prevalence of radiographic findings in people who are asymptomatic. And what you find is about 21% of males and 3% of females will have a pistol grip deformity, even though they're asymptomatic subjects with no concern about hip pain or impingement. The femoral head neck bump you see in 10% of males and about 3% of females, and you can get lateral head flattening in about 14% of normal males. And then if you look at the figure of 8 or posterior wall sign, increased acetabular coverage, and the crossover sign, which is the figure 8, sign we see here, what you can see that they're extremely, all of these are very common in asymptomatic individuals. So I think it's really hard to hang your hat on X-ray signs, especially in males. So this was a study in 2014. CT findings of FAI show equal prevalence in young and old asymptomatic subjects without osteoarthritis. And so the concern that a lot of people had for some time was that femoroacetabular impingement was a risk factor for developing osteoarthritis. And what this showed is that CT findings of FAI do not correlate with the development of osteoarthritis. So this study says, at least if you base the diagnosis of FAI on X-ray technology, it is not a precursor to the development of osteoarthritis. And consequently, if you're doing FAI surgery, you shouldn't do it to keep people from getting degenerative disease, but because of the anatomy being a mechanism for degenerative disease, you should base surgery on the clinical findings and the symptoms of the patient and not the X-ray findings. So this is a recommendation of findings that should be in an MR report if there is a concern of femoral acetabular impingement. So they recommend that the acetabular version be in the report, the amount of acetabular coverage, whether there's labral disease, whether there's articular cartilage disease, the head neck junction morphology, abnormalities of the surrounding soft tissues, and then obviously bone marrow abnormalities. I think in general, the acetabular version is not commonly presented in an MR report, but it's something to be concerned about. So now with MR imaging, what do we look for? For cam type impingement, we look for the femoral head neck bump, and we can measure the alpha angle, and we'll talk about different ways to do that and what are more or less sensitive. And then we'll look for bone injuries. And I think that the bone injuries, especially bone marrow edema, is one of the more useful findings in trying to help us determine whether we have a clinical cam type impingement or whether it's just a morphological variant that's not important. And then the treatment for these, if it's believed that the impingement is a cause of the patient's symptoms, you remove the cause of the impingement, which would be a bump resection. If the labrum has been torn due to repetitive trauma, you in the old, this is several years old, a decade ago, people would do a labral tear removal and then a microfracture if there are areas of articular cartilage abnormality. Since then, studies have been shown to show that you are much better off if you repair the labral tear rather than remove it. So now this should read labral tear repair, not removal. So the traditional way of doing a cam type for an alpha angle for cam type impingement with MR is we do oblique axial images through the proximal femur, and we take the middle cut. And when you take the middle cut, then, and you've all done this, but I'll just review it again. You draw a line down the center of the femoral neck. You put a circle around the femoral head. You go to the center of the circle, then you draw a line right where the circle intersects the bone, and then measure the alpha angle. Originally, it was thought that normal was less than 55 degrees, and abnormality was greater than 55 degrees. And then as people started looking at more and more individuals, they found that if you use 55 degrees, then the majority of the people who you will measure who will have abnormal alpha angles will be asymptomatic individuals. So this is probably too sensitive and not specific enough. So most people now use a 65 degree as an abnormality. Though this paper says 60 degrees, most people now use about a 65 degrees, but some referring physicians prefer higher sensitivity and some prefer a higher specificity. So it's best just to give the angle and then leave the interpretation, unless you're asked to, up to the referring physician.
Campbell's talks about 50 degrees.
50 degrees. I've never heard of 50 degrees.
And it mentions 50 degrees. That's something that above that is something below that is what you worry about. The other thing is the CAM patients are more athletic historically, and they're mainly males. You don't see CAM as often in females.
Right.
So most times when you're looking for CAM, it's going to be.
Yeah, unless they're gymnasts. If they're gymnasts, you can see them in females. Otherwise, it's mostly males. That's right.
Well, gymnasts, that's a different ball of wax.
Right.
And they're kids, by the way. The other thing is, when I was reading in Campbell's, they did a lot of details, and the numbers just keep flying around. And the results of surgery and so on are not that exciting. And so, although there's a lot of detail used, but in terms of surgery and so on is exactly what you say, John. If the patient is asymptomatic, leave them alone.
Yeah. Good. So this is a view on a T1 weighted image of the oblique axial sequence through the proximal femur. Here is a protein density fat suppressed sequence, which has the advantage of being able to pick up bone edema. In this particular case, I want you to notice how poor the quality of this image is. Anybody want to say why this is such a poor quality image? Jennifer, why do you think this is not a great quality image as opposed to the T1 here, where the margins are nice and sharply defined? Well, if we do it again, it could look like this.
Right. So, okay, so we're seeing some flow artifact from the adjacent vasculature.
Yeah. So, yeah, if you see that this is actually all flow artifacts. See all this noise coming across here? So the one thing to remember when you get out in practice, if you do these images, especially if it's a fat-suppressed, fluid-sensitive images, make sure your phase encoding is anterior-posterior, so any flow from the vessels is projected away from the hip and not onto the hip. and then you get much better quality images. Okay, Ashley, what do you think of this case?
All right, so we're looking at two coronal images. Looks like there's an abnormal convexity along the superior, at the head and neck junction of the superior femoral head, and there's actually some cystic change there, so that's kind of consistent with.
So I'm pointing out the cystic change, and something you'll commonly see in x-rays is a little cyst in the subchondral bone associated with the lateral and anterolateral aspect of the femoral head near the head neck junction. And what's that called?
The pit?
It's a Pitt's pit, after the radiologist Pitt. What's another name for it? It's also called a herniation pit. And for a long time, at least what I was taught when I was in residencies, that these were congenital lesions and you could leave me alone and forget about them. But I don't believe they're congenital lesions anymore. This actually was also associated with a little degenerative osteophyte there, which we can see there. Well, actually, what am I doing here? Okay, so these are typically in a location in the area where you get the kind of impingement when you have flexion with internal rotation. In this particular location, I believe now it's generally believed that these are due to repetitive trauma, just like we see subchondral cysts elsewhere in the body and all the other joints that we've been talking about. In this particular case, we can see that there are a lot of marginal osteophytes here, which puts this patient at increased risk for cam-type impingement. And if we measure an alpha angle here, it's very large. It's 85 degrees. And here's just from the literature, another abnormal alpha angle from the European literature. Now, so here we can see an anterior bump. We can see a little bit of bone marrow edema associated with the bump in this location. If we measure the alpha angle, it's kind of right in between, right around 65 degrees. Now, another way to measure this is called the anterior femoral distance, where a person, where you can take a line along the anterior cortex of the neck of the femur through the head like this, and measure the distance at the area of the bump from this particular line. In this case, it's 0.72 centimeters, and abnormality is greater than 3.6 millimeters. This is 7.2 millimeters. So this would be abnormal. This is in the literature. I don't know very many people who use the anterior femoral distance as a measurement. Okay, here's another patient with a cam-type impingement with an anterior head neck bump, and then with an abnormal alpha angle. Now, other findings that you can see with cam-type impingement, if you're going to be impinging the femur, then that's going to be impinged against the acetabulum. So you also need to look for injury patterns to the acetabulum. And this is a very common location. You've already seen hundreds of these this year. You typically will get bone marrow edema right involving the anterior lateral subchondral bone of the acetabulum. That's where the impingement occurs on the acetabular side. And consequently, this is also where we commonly see subchondral cysts on the acetabular side, again, in this location here. So that's a very characteristic pattern in a cam-type femoral acetabular impingement. The other thing you look for, also if you have trauma involving the anterior acetabulum here, that's also where you have the anterior portion of the superior labrum, and we can see a nice tear there also. So that's the other thing you look for. So here we can see that little cyst on the femur. We look for cystic changes of the anterior superior aspect of the acetabulum. We can look for labral tears, look for cartilage disease, which we'll talk about in a minute. And then, as we talked about earlier in this lecture, you can get these os acetabulae, which are probably due to fractures of the acetabulum from the impingement. So those are the things to look for and comment on. So here's the oblique axial image. We see the typical subchondral cystic changes in this location. This is extravasation of contrast from the arthrogram and the bump. See, all characteristic of cam type impingement. Okay, Michael, what do you think of this case?
Okay, so 31-year-old MLB pitcher, chronic hip pain and stiffness. So we see that bump, that prominent convexity of the anterior femoral head neck junction. So I'd assume you'd probably have an increased alpha angle if we measured it. Measured, let's say 73. I can't see.
I think. Yeah, 73, I believe.
Okay, so 73. The portion of labrum we could see on that first image looks okay. Now I'm wondering if there's increased signal maybe involving that superior labrum right there. Is this a arthrogram? That's not joint fluid, right?
I think that's joint fluid.
If it is, it's pretty big joint effusion, and it looks like there's probably a conglomerate of perilabral cysts superiorly as well associated with that labral tear.
Yeah. Here are the fat suppressed images.
And now we can more clearly see that tear at the contralabral junction secondary to the impingement.
And that's the perilabral cyst going on.
Perilabral cysts. Yeah.
Is it possible that there's a little bit of a slip capital epiphysis in this case, John?
Yeah, that's very possible. As I talked about earlier, this one would be very subtle, so I wouldn't call it just on the imaging alone. But it's very possible, and I think the subtle slip femoral epiphyses are a risk factor for the development of this disease in athletes.
And that's what I understand. When I was seeing kids at 14, 15 years of age with the problem of slips, that was always in our mind.
Yeah, good.
Bumpectomies in the future.
Right, good. Okay. Now, if we kind of go to the Pincer type, this is really due to overgrowth of the acetabulum. And here, typically, you can get impaction anterior and superiorly, but what's often seen by imaging is you get a posterior inferior bone injury, where you get a leverage effect and bang the posterior inferior aspect of the femoral head neck junction against the acetabulum, and that does not occur with typical cam type. So this can differentiate the Pincer type from the cam type. And the treatment of these is do an acetabular rim resection.
You can also get both.
Most of the time. Most of the time you get both. That's right.
And the surgery is a little complicated, and open procedures are quite common, although arthroscopic procedures are probably more common these days, but right. The results are not all that exciting in the way I see it.
Yeah.
I've never done one. I've never watched one, but when they talk about what they do, it doesn't give me the logical reasons for doing it. Most of these cases are in their 50s, and so I figure, why not wait a little while if the patient can tolerate it, and then do a total hip later.
Yeah, well, most of the ones we look at are young people in their teens and 20s, because they're athletes who come in with symptomatic disease. But certainly this can get worse later on as you develop more degenerative changes. In terms of looking at Pincer type.
Yeah, that's a different ball of wax. The Pincer type is more in females. That's gonna different ball of wax.
Yeah, so this is over coverage, and there's a debate about how to best do this. One technique that Fearman from Europe uses is you get the center of the acetabular head in the oblique axial images, draw a line through the center, and then draw a line through the bony margins of the acetabulum anterior posteriorly, and the acetabular line should be medial to the center line. If the acetabular line is lateral to the center line of the femoral head, this is risk for pincer type FAI, whereas down below would be normal, non-over coverage. But sometimes it's hard to get right in the center of the femoral head. And the other thing that you have to realize is that pincer type FAI, just like cam type, can be very focal. And if the focal area of impingement is not in this midline image, then you're not going to be able to see it. Now, secondary signs that you can see with pincer type impingement is a irregularity of the posterior inferior head neck junction, as we're seeing here, especially this little divot in it. Personally, I don't find this very helpful, but this is a sign that has been described in the pincer type impingement. A more common sign that I find more helpful is degenerative disease of the posterior inferior acetabulum down here. And this is almost all other degenerative disease is primarily going to involve the superior weight-bearing portion. And obviously, cam type impingement is going to be more anterior superior. So this posterior inferior degenerative disease is highly suspicious for pincer type abnormality. And then you look for over coverage. This is a very abnormal center edge angle where the acetabulum is extensively over. In fact, there's probably some protrusio here where the head is very deeply inserted into a very large acetabulum. And you also see some little marginal osteophytes here. So that's typical impingement. And the most extreme form of pincer type impingement would be protrusio-acetabular, which we can see on both sides here. And here's the MR appearance of protrusio-acetabulae, and you can see that you're going to have marked limitation of motion on both femurs bilaterally, and much motion at all is going to produce impingement in this particular patient. And you can see the hypertrophic bone formation, which has occurred circumferentially here at the head neck junction due to the impingement.
Campbell's talks about anteversion some, but the way I see it, that you're getting a little more of internal rotation. So I don't like the word anteversion, never have.
Okay.
You can see the rotation or not, because like if you're looking at the AP view here, you barely see the lesser trocanthers. So you're not really getting a true view of what the pelvis is. You should see the lesser trocanthers better than what you see them. This is almost like you're looking at something that's subluxed.
Okay.
It's not subluxed, but nevertheless, you should see more.
Okay.
I don't know. Nobody's written about that I know of.
So this is really an external impingement, which are large anterior inferior iliac spines, which produce basically an extra-articular impingement, which occurs when you have flexion, adduction, and internal rotation. But this is another form of hip impingement, which is not typically considered femoral acetabular type impingement. It's due to enlarged anterior inferior iliac spines. But the symptoms can mimic FAI. So this is just an important thing to remember. If you see it, this would be a different kind of surgery, a different treatment than the typical FAI that people think about with sports injuries. Some people also call this subspine impingement.
And this didn't come into existence in maybe 20 years ago. I think it started maybe, 10, 15 years ago talking about this, John?
Right, yeah. Right.
So it's kind of a recent type of a discussion on hips.
Yep. Okay, Jennifer, this is someone who has hip pain.
Okay, so it looks like we have two sagittal images of the hip, and they're is increased signal intensity and irregularity of the anterior superior labrum. It's kind of blunted. Looks like it could be chronically torn, and there may be some adjacent chondral loss there.
Right.
And here again, we have adjacent chondral loss and diminutive blunted appearance of the superior labrum.
Yeah, it's a superior, and it goes kind of into the anterior labrum, and that's typical of a cam-type impingement.
It's like chondromalacia.
Yeah, right. Let's see, Ashley, what do you think of this case?
There's moderate chondral thinning and possible loss along the superior portion of the femoroacetabular articulation, and there's some subchondral edema and maybe some minimal cystic change as well. The anterior superior acetabulum looks a little bit irregular, but it looks intact.
Yeah, and this is a chondral injury, right? Okay, Michael.
Okay, so another MLB player, acute versus chronic. So I see in the superior acetabulum there's some sclerosis and subchondral cystic change, as well as probably there's some labral irregularity.
Yeah,
So I mean, and there's some edema
here. Yeah. So
yeah, and then there's some edema kind of superior to that aspect. So I guess this can be seen in a cam-type impingement.
Yeah, well, what they were concerned about is this acute or is it chronic disease? That was what their question was.
Oh, well, I mean, there does look to be some kind of more acute appearing marrow edema, but there is subchondral cystic change, which has to be chronic.
Yeah, so that's chronic, and I don't really see any real edema here on the fluid-sensitive images. If we go to the sagittal image, which is a little bit better.
And that just looks like a well-defined subchondral cyst without any edema on the sagittal stir.
And there's a little bit of irregularity of the articular cartilage here, and maybe the labrum, but the labrum is not really displaced. And this was chronic degenerative joint disease. Okay, Jennifer. This is
all right, so we have a 17-year-old female with hip pain, and we have MR arthrography without traction. So we have increased signal at the chondrolabral junction of the superior labrum, and there's just detachment, and there's also some regions of high-grade chondral loss along the superior joint space. I think this could be seen with FAI and labral tearing and chondral loss.
It's the same patient.
Okay. I would want to look at the T1s and just see if any of that is ossified.
What's the difference between this image and the previous image? Okay, so this is with traction. So they were doing studies where they would do an MR arthrogram of the hip and image the patients normally, and then with axial traction on the femur. And it's what they found is you could see these flap injuries of the articular cartilage and the labrum much better if you place the hip under traction. So
yes,
you can actually see that interstitial tearing and the flap, all the different flaps here much better when it's under traction. And then they correlated these with arthroscopy and found that traction was very helpful in seeing a lot of these delamination type injuries. Despite that, very few radiology groups are equipped to do the imaging under traction. So we don't do that, but that's just something that's kind of interesting. So then what is the accuracy of non-arthrographic 3T imaging and intra-articular pathology at arthroscopy in patients with femoral acetabular impingement? So you can see very high sensitivity for labral tears, though the specificity was not so great. Cartilage, not too bad, 85% sensitivity, high specificity. So actually, overall, the statistics weren't too bad for regular 3T MR imaging of the hip compared to arthroscopy. What is the value of 3D printed models in preoperative planning? This is just some surgeons kind of like the 3D models, but I don't know anyone who routinely prints 3D models from the imaging information. So this was a study that looked at preoperative findings and correlated them with outcome in patients who had arthroscopy. This is getting a little bit toward what John was talking about in terms of what outcomes occurred. So they looked at patient age, patient sex, whether or not putting anesthetics in the joint relieved their pain. They looked at labral tears by MRA, labral tears by arthroscopy, tear size by MRA, cartilage grade by MRA, and cartilage grading by arthroscopy. So ask you, which of these do you think correlate well with one-year outcomes?
I would say that labral tear size by arthroscopy.
So none of these showed any statistical correlation with the patient's outcome findings at 1 year after surgery. So this is getting to John saying that the efficacy of surgery is somewhat questioned by some people. The only thing that actually correlated well was BMI. Less than 25 BMI correlated with good outcomes. BMI greater than 25 correlated with poor outcomes. So what can actually post-operative findings, what correlates with poor outcomes? And here you can, what correlates with poor outcomes are inadequate osseous resections. If you see intra-articular adhesions, that's important. Malpositioning of the sutures, which I find something they can't really evaluate by our imaging studies, but by repeated arthroscopy. Bony stress reactions are a negative outcome. If we see evidence of instability, Labr's degeneration, chondral injury and degeneration, worsening, infection, and osteonecrosis are things to look for after the patients have had surgery. Okay, so Michael, what MRI findings after hip arthroscopy differentiate symptomatic from asymptomatic patients? Any thoughts?
You mean like after they do arthroscopy for impingement?
Yeah, what MRI findings after they've done hip arthroscopy are seen in symptomatic versus asymptomatic patients? Yeah, I would expect that increasing bone edema would probably be seen more in symptomatic patients. I would think that maybe if they didn't have adequate resection of the anatomy that we thought was doing the impingement, that they should have worse outcomes. And so what found is that capsular and paralabral adhesions had no correlation with symptoms versus asymptomatic. Labral tears had no correlations. Cartilage defects had no correlations. And capsular defects, none of these correlated or could differentiate symptomatic from asymptomatic patients. Possible correlations, if they had labral resection, it was more commonly performed in the asymptomatic group. But there are other studies that show that the patients who have labral repair versus resection, the labral repair group does better than the resected group. Okay, Jennifer, what do you think is going on here?
Okay, so here we can see some edema and cyst formation within the right superior acetabulum. And it looks like they may have a bump there at the superior femoral head and neck junction.
I think you've got a circumferential head neck junction osteophyte, got complete loss of the joint space there, a lot of findings in that big cyst, and this is just degenerative disease.
Okay.
Yeah. So patient had mechanical pain, and here again we're getting degenerative disease with subchondral cyst formation here in this location. And this patient went in and had surgery. We can see that there's some cartilage loss here, and they continue to have pain after the surgery. Okay, Ashley, what do you think of this case? John?
Yeah, do you think that rotation of the femur is not counted enough in terms of preoperative examination?
That I don't know, John. You mean by imaging or by physical exam?
Both.
You mean the torsion? The torsion
Yeah,
of the.
exactly.
It's
All the femurs, every patient that I've ever examined, I always make sure that they're not knock-kneed or bow-legged or internally rotated or externally rotated at the femur or the tibia, etc., etc. And I get the impression that when you all you do is look at MRI and not measure what happens clinically, you get into trouble.
So
When
the way we do the imaging, we don't image the knee, so we really can't make that determination except if it's a CT scan before having a joint replacement, and then that's all carefully measured, and it's done electronically, and it's put into the computer so that when they do the cuts for the replacement, they take that into account.
Yeah, with the total hips now, they're starting to use computers to help with alignments.
Right.
And even Campbell's clinic finally has decided that that might be helpful, although they haven't decided yet. And they're going to the anterior incision instead of posterior, which they've been happy with for many years. And finally, and for some reason, Campbell's doesn't mention Dr. Mata very much, who was one of the pioneers in anterior surgery, which is the way to go.
Okay.
I'll vouch for that.
All righty. Yeah, you worked with him. Okay, Ashley, what do you think of this case?
49-year-old female with hip pain, rule out labral tear. Looks like there's quite a bit of chondral loss and irregularity along the superior margin of the femoro-acetabular junction. There's some subchondral cystic change in meroedema and also meroedema within the femoral head. And there's some marginalized osteophytes and some irregularity along that recess as well. I think there's some irregularity at the ligament teres, inferiorly, extending inferiorly there.
We only have one cut, so you have to really look at multiple cuts to look at the ligament teres. But I agree with you, in their place of loose bodies down here. Again, degenerative disease, and it's not someone, the labral tear, there was some degenerative change of the labrum, but it wasn't displaced tear, but that's not the issue in this particular patient, it's the degenerative disease.
That's for sure, John.
Yeah. So here's a question, Michael, to you. How are patient outcomes affected by intra-articular therapeutic hip injections for osteoarthritis related hip pain?
I mean, are we talking short term or long term?
Both.
Both. Well, I mean, short term, some people do get some pain relief.
Okay.
For steroid injections, but overall long term you can speed up the degenerative process of the joint if you give multiple injections. Yeah. So long term it's not going to really do much. It's just kind of like a temporary band-aid.
I advise against it.
Yeah, and that there's a big concern now. Also, if you put in anesthetic agents, now we know that almost all the anesthetic agents are actually chondral, irritate the articular cartilage and are thought to lead to accelerated degenerative loss of the articular cartilage. So this is a concern. Most people believe the way you did, Michael, that short-term people would get better and long-term it wouldn't be so great. But this was really one of the first well-controlled studies from a large group in skeletal radiology in 2019. And they basically showed that there were no significant differences between the control group and the non-control group at both short, which were I think a week or two, and 6 months intervals after hip injections for steroids. So their recommendations weren't to do it.
Did they give placebo or like sham injections?
Yes.
I have a hip injection.
Yeah. Okay.
You should tell them they should cancel it.
No.
If you're going to do it,
I know people
don't.
who swear by it, so this is just a larger study. So it's very controversial right now, and skeletal radiology circles.
In my opinion, use as little of the anesthetic as possible, other than until you get to the joint. You can use as much as you want, but once you get to the joint and you're going to perforate it, then don't use too much anesthetic inside the joint at all.
Okay.
Maybe not use at all, any at all. Just use the cortisone.
Yeah. Of course, here's what they're recommending. They're saying that cortisone is not helpful, but that's
Well, it may help with pain for a couple of weeks, and it might be just enough to get somebody over the inflammatory process.
And here's an arthrogram. We see a lot of marginal osteophytes and degenerative disease. And this is actually just a little chondral flap. I'm sorry, that's right. This was a hip plica. You can get plica, and this would be adjacent to the ligamentum teres. You can also get chondral flaps that can look like this, but there are things to look for and describe. Okay, I think, why don't we stop here, and we'll continue this and go on to the next lecture on Thursday.